I want to give gold stars, but I do want to foster questions. And I guess there has to be something that people want more than life itself. And I was thinking, since we're going to be cooking these tomahawk steaks, then there's might be 2 or 3 of them. I'll have to take a head count of who's actually going to come over to the barbecue after.
You're listening to the Restoring Human Movement podcast, where movement experts discuss the latest evidence-based practices to help you and your clients move with mastery. And now, your host, Dr. Sebastian Gonzalez.
Hey guys, it's Dr. Sebastian Gonzalez, your host with the Restoring Human Movement podcast. Thanks for joining the movement. This is a podcast today that, by the way, if you have not been listening to the podcast before, welcome for your first time. This is about an hour or so that you're spending with me and hopefully becoming a better clinician and being able to communicate better with your patients and saying things in a way that's something they can understand. And if you have heard other podcasts, I've described this podcast as kind of like 2 docs having a beer and then your friend who's a CPA is just listening over your shoulder saying, hey, what's that mean? Hey, what's that mean? Hey, I got this back thing. What do I do about it? And so we can't explain things in a extremely complicated way because they wouldn't do that to us. We're talking about taxes. So today is a little bit of a different one, and honestly, I don't know if I'm even going to release this one. It was just a thought that I had this morning where I've been writing this workshop it's a continuing education workshop. And I hit like a roadblock, and I had seen an Instagram post where someone was saying that docs basically need to take time to sit there and think about what they're doing rather than always presenting and always being with patients as well. And so it just happened to run upon me on a day where I guess I kind of needed it. Not that I like inspirational quotes on Instagram. I kind of hate them, honestly. But for the most part, I thought as I was going through this today, I had to text a couple people and ask if they had some suggestions. And I ran into by the way, if you don't know if this workshop I'm creating, I'm trying to relay all the information that I know and that I've learned over the last few years that have really helped improve my practice. And not necessarily in a way of getting patients in the door, but for the most part, just getting patients to respond to load and be able to become empowered. And so I've incorporated a lot more active care. And by active care, I mean the type of active care where we're getting someone to do, like say it hurts to squat, we cue them in a certain way to make it so the squat actually becomes pain-free. And so I kind of call it offloading structures that are generating symptoms or movements that are generating symptoms. And so when at all possible, I really try to load people, whether it be from a simple core exercise on the floor, whether it be from a high diagonal sit, whether it be from crawling on the ground and using gravity as a load, or getting them into a more aggressive thing. Like I've had people come in and say, hey, I want to do a full pull-up, and that triggers my symptoms. And I've had people who take almost every weight in the entire place and load it on a barbell, and that's the way they trigger their symptoms. And so it's all about if you can get the person, I think, into a more empowered position, if I had to say it. But anyways, as I was going through this today, all these ideas that I have and the way that I practice, I've really been challenged over the last, especially since I had my last intern, my first intern in a while. It was Jeremy. I was challenged to explain things so he could then take the bits and pieces that he wanted and apply them to his practice. And so now I have a few more interns that have come through and shadowers, and it's tough. It's tough to put things together in an organized fashion for people to figure out how they can use it from a clinical standpoint. So I'm going to go into that a little bit today and just kind of like brainstorm. I guess this is my reflection and my thinking, and I'm just open micing it. I have no agenda today. I don't know what I'm going to be talking about. It's just I'm going to be perusing through my PowerPoint slides that I've made, and I'm just kind of remembering of what I needed to do and maybe how I can make these slides better. Now, if this is your first time to the podcast, by the way, I typically share a little bit about myself via story, rant, or something I like or don't like. And so I'll share that story with you now, and then we'll get right back into the relevant content of the day. All right, so going through airports, do you ever notice that people are wearing the shittiest hats? It's like the largest, most ostentatious hats that are not relevant to the situation. Like you can be in Seattle and it's raining and someone is wearing a sunbonnet. And so next time you go, just check around. And here's my theory with this is that everybody has these big-ass hats and they can't fit them all in their luggage, or they don't want to crush them. So actually last time that I went to the airport, I looked around and I just observed everyone's hats. And lo and behold, someone had a hat on that was just ridiculous looking, or it was not appropriate for the situation. And he actually had a second hat on. So he actually had two hats on. And so you'll probably notice people going through and having big old jackets and all this kind of stuff. It's stuff that's not relevant to the situation they're in currently because they want to get it all to their destination, obviously. So next time you go to the airport, check out all the weird hats. They're going to be all around you now that you see them. All right, so back into the idea of kind of formulating ideas. I know that I've in the past not been a big fan of, say, your algorithm standards. This is how you do things. This is the box you stay in. This is the method you use, and this works for everybody. I've not been a big fan because I know that there's more to it than that. And the other day, I don't know if it'll air prior to this podcast or not. I think it will. I interviewed Dennis Dunphy from Stick Mobility, and we're talking about application of systems. And so they do a 2-day workshop on just generating tension, or as he would call irradiation, through finding what point is most optimal to get the stimulus needed to get the person to feel what they need to feel. And just kind of cleaning that up a little bit is we might, like in my clinical practice, sometimes I'll get people to load into a single leg hinge, and I'm trying to bias the hip or bias the gluteals to help out with buttressing and supporting this movement because it's a painful movement for them. And so I teach it in a little bit different way to each person based upon what they're telling me and the feedback they give me. And so it's not really about the exercise, it's about the way it's applied. And so after talking to Dennis, he was kind of saying that people, so they would go through the things that they think are most relevant to the trainer, the coach, or the clinician. And then so he'd have people that would ask him after, hey, can you send do you have video exercises of the exercises we did? And he's like, yeah, but it's about the application. You need to use the tool to generate the finding you're looking for. And so it's all about figuring out what works best for that person. And when I'm putting these ideas down on paper, and so I'm going through just some rough ideas of, I call it buttressing, or supporting the movement. And I thought about, so I'm going through the hinge, squat, carry, push, pull currently. And so I've got into the hinge here, and I looked up, I want to have a lot of pictures, or enough pictures to give people ideas of what I'm looking for. And so I think when most people think of the hinge or the hip hinge, they think about deadlifting. And so I looked up variations of deadlifts, and what popped up, I looked up on images, and what popped up was, let's see, let me pull up that slide here. There was someone showing hip hinge with the dowel, kettlebell deadlift off a plate, kettlebell deadlift on the floor, trap bar deadlift, barbell deadlift, and then there was a deadlift with a deficit. And so I saw a bunch of double leg options. I didn't see a lot of singles. And so I thought, well, maybe I'll just show the singles because these are kind of sagittal plane dominant, as I would consider if we're thinking about planes of movement. And I don't think we're not on two legs all the time. A lot of times we're walking and in an athletic position and changing direction. So I like to challenge a single leg. And so I thought about making a slide where I was putting together, first I wrote sagittal plane dominant, and then I wrote frontal plane dominant for the next slide and transverse plane dominant. And I was thinking back from when I had gone to a Koichi Soto's seminar. He was talking about the hinge and the squat in these other planes of movement, and I thought, oh, that's great. I love it, right? You're treating the ball socket, at least of the hip in this regard, as a three-dimensional movement generator. And so you need exercises or stimuluses to train the person to do so, to have command through it, kind of like giving the venom as an anti-venom. And so as I started to write these things down, I started thinking, well, am I really do I care about the variation of plane of movement, or am I trying to bias or buttress the movement? And so as I'm trying to relay some of the methods that I use to get people to decrease their symptoms without even having to do any tissue work or adjustment and so on, and a lot of times they fall into this buttressing category very early for me, I'm trying to figure out how to relay this. And so I wrote a slide that mainly kind of made me think about doing this podcast today, is that it says variation for biasing or buttressing versus variations of plane of movement. And so I don't know how I want to teach this spot. I don't know. I want to make sure that people don't fall into the category of using it like a corrective exercise to say, well, we did a sagittal plane one, so we need a transverse and a frontal, and that's what this person needs all the time, because it's not. And also, too, if we're trying to, are we really trying to teach people as a trainer or coach, as a clinician, or we're not? I don't think we're trying to take anyone's job away. At least I'm not. Like I want to troubleshoot the person and see what we can do to create the stimulus that we need to buttress and support the movement, to offload the pain-generating structures. And so, in that regard, I feel like I just want to go through and list a bunch of things that are my go-tos. And so an example would be with this hip hinge category, instead of going into, the progressions of like your deadlift all the way down to a trap bar, to a barbell, to a deficit, I would probably keep people a little bit higher on a plate or on blocks, and then I would tangent them a little bit into single leg variety. And so for some people with the single leg deadlift or SLD, sometimes I'll use an analogy, and these people they can be super conditioned, or they can be very deconditioned. And so I'll have them stand on one leg and just ask them what happens, and they'll say, "Well, I feel." Say, "What do you feel working?" They say, "Well, my thigh." And I'm like, "Well, if I want to get you to bias the movement that is symptomatic for you by using another area, at least for now." By the way, I don't think there's any right and wrong in this. It's just what's right for that person. And so if I'm looking to use the gluteal regions, then I might have them cross the hand and the foot across just to counterbalance. And they say, "Okay, I feel more hip now." Good. Well, where do you feel it? And so they point, and sometimes they point, which I had someone the other day did this, and they said, "Well, I've been doing this for a little while, and I do feel my hip, but when you say hip, what do you mean? Or in the gluteals, what do you mean?" And she points down at kind of like, I guess it'd be the glute max insertion, kind of way down there. And I interpreted it as, since she's been having some issues into the calf, I interpreted it as it was more of a, let's say, high hamstring, or maybe a symptom. Crap, I gotta stop touching that mic. Maybe it was a symptom that she was interpreting as the feeling I was looking for. And so with her, I stood on the side of her, on the side of the stance leg, and I said, "I want you to lean into me a little bit, but don't push me over." And so when she did that, she started to feel the outer part of the hip, or the lateral aspect. And I said, "Have you felt this before during this exercise?" And she said, "No." And so then I challenged her with a band, and she did feel it, and we used the opposite hand, the contralateral hand. And also, too, we did use a weight. We used a kettlebell. And so it's funny to see that when people are doing these exercises, again, it's not about the exercise, it's about how the person does the exercise, and is it therapeutic to them. And so I guess with this exercise, too, I guess I can categorize it as a frontal plane one, I think, right? Single leg stance, but also, too, if you allow them to completely dump, they'll rotate about that hip. So now we have transverse, too. And I don't know if any exercise that I've ever seen is purely one plane or another, but I guess we can say dominantly the way we cue it, we're biasing a certain plane more than another. And so my biomechanics in this might be a little bit off, but for the most part, I guess the vulnerability aspect of it is I'm kind of freaking. I don't know what the fuck I'm going to teach. I think I know what the end result I want to get for the attendees, and I know the end result I would like to get for the interns that come in, but I don't know how the hell I'm going to teach it. And so I don't know if you guys, I'm sure I might do a workshop on another date after this, or I'm sure I'm going to have more interns. And so if you have any ideas of maybe how to clean this up for me, this is, I guess, why I'm doing this podcast, is I'm trying to brainstorm. So I don't know. And I guess back onto the idea too, with all of these, like you have your FMS and SFMA and, all these places that have this algorithm and they're trying to make it easy for us. And I see that. And then again, in the past, I was like, that not everyone falls in this box, and there's going to be outliers, but it's hard to teach those outliers or how to teach how to work with those outliers unless you teach the methodology of what you're looking to accomplish. And so that algorithm doesn't always work, and the same exercises don't always work for everybody because they can cheat them a little bit, or maybe we didn't get the right data through the examination. And so I think what I'm going to do in the course is I'm just going to go through variations of things that have worked for me, and I don't know what the hell to call them all, and I was looking for exercises online and images that would demonstrate the principles that I'm looking for, but I don't know if I'm going to find them, and I feel like I'm going to have to take my own pictures with this and just troubleshoot with people. And quite honestly, the thing that scares me to death with this workshop is that if people don't ask questions, I have less to say. And I can always go down a rabbit hole of chasing something kind of like, you guys know it by now, if you listen to podcasts, I can talk for a little bit. But I want to talk about things that people care about hearing about. And I think they get the most information from me if they lead the conversation, although I'll go off of a rough framework. And so I don't know if they do this with all the workshops. I know Justin Dean does a good job in his workshop of tangenting around. It's just a clinical audit process. And so it's just kind of finding what works for that person, and here's some ideas to try. And so that's kind of how I want mine to go, and I'm just going to propose the variations and just see what it comes to. And I'm hoping to God that people have some type of thing that they're concerned about, because case studies, in my opinion, would be golden. They'd be great. Like I love to troubleshoot and follow the trail that the person provides. But if there's no trail to follow, we're all talking theoreticals, and then there's no proof in the pudding. I can tell patients all the time, it's like, look, you might come in with an idea of what you think will work, which is fine. I'm open to trying that with you, but at the same time, the proof's in the pudding. And if you feel if we pick a certain if you pick a certain movement that creates a symptom, I'm in the department to decrease that symptom for you while you're doing the same movement by buttressing that and giving you some type of other stimulus. So I think because of that, I mean, I lean towards loading people early and often. And actually, recently, yesterday, by the way, this is I'm recording this and still it's May 1st right now, May 2nd, about Cinco de Mayo. So just so you know, kind of like where I'm at in regards to timeline of things, because that workshop is going to be in June 8th this year. So I don't know if it's going to release prior to that, but I thought the brainstorm would be useful for you guys. So I was contacted the other day by a government agency to help out with some of the I don't want to say conditioning, but kind of creating some video content for people who are people who they don't want to become long-term issues. And these people, like, they're active. Like, I'm being a little vague because I don't know what I can actually talk about here. But for the most part, these people are they're active. But also, too, based upon their observation, these people become very defeated and feel like they're broken after they have some type of issue pop up. And so I was contacted by the agency to kind of put together some videos of kind of empowering those people and letting them know that, like, say if they have a back issue, like it's not they're not gonna spiral the drain, and here's some things that we typically can do in office to decrease them, and here's ways that they can typically prevent it from occurring. And obviously, like I had told them, I'm like, look, all these types of cases are different, so it's very hard to make something standard like that. But I can give you, beyond reasonable doubt, like what I would do with a lot of these people, and I can make a video about that. And so before we actually create it, we chatted about it. By the way, at this point in time, it might have been created. I just don't know if we're going to continue. Is that one of my friends basically referred me to be the person for this, and so I told her that I said, look, I want to do it. Like, I want to help out, and this is right up my alley. I've done well over 300, probably 350 YouTube videos. I've done a shit ton of podcasts by now. Like, I don't have a problem with speaking on camera, and I know my stuff. But I said, quite honestly, I think there's a possibility that if I'm walking into like a department, that they might have a past belief system of what they are open to doing, or they might have a standard of care that they like to go through. And I said, if they're not going to give me free range to do what I need to do and what I'm good at and what I excel at, then I don't see any point in having me. And not that I don't want to be a part of it, but it's like, if you need a spokesmodel to promote your style of care, then you don't need me. And so I was talking through email. I said, look, let's just make sure we're on the same page. And so I laid out what I would suggest and what's worked for me, and a lot of it was loading early and often, and within obviously unless contraindicated. But they kind of came back with a little bit of they were talking about passive range of motion, then through active range of motion. After that, and I thought, I was like, I honestly I don't do that. I'm like, I don't know what population you're working with, but I don't think I've taught passive range of motion in a very long time to a patient. And I think if the goal is to get these people to feel really good and empowered, I think we load them a little bit unless it's contraindicated. And so I basically said, I don't, if you guys have a type of care that you want to promote, that's like, I'm not good at that. I'm not good at doing that. Like, maybe these are post-op, maybe they're trauma-based. I have no idea. And if we're looking at overuse type of models, I guess, quote unquote, or people who had things kind of pop up, they want to slip and fall and weren't a surgical intervention, then like all day, like I'm like, honestly, I load them on day one. And so I don't know what'll come of it, but for the most part within this workshop, that's what I want to relay to people, is that these are very viable options, but it's going to take testing on your part. So I don't know what. It took me a long time to learn how to do that kind of stuff, but so I guess I'm just kind of Pandora's box for people. And as I create this workshop, it's I guess I've said this a couple of times already. I guess it's repeat myself by now, is it's really tough to get my ideas out. It's really tough to organize my thoughts, and I'm really second guessing if I should do this or not. So. But as with all the feedback I've gotten from the podcast, it sounds like it's going to be a good thing, but I don't know for sure. Anyways, I don't know. I don't know if this podcast is going to air. I don't know if I have that much to think about. But we'll see what happens here. So I think one thing though is I created a whole group of slides based upon tension. And just looking for signs of if the people can generate tension or not. I don't remember where I got that concept of tension. It's probably from Dan John, maybe from Cody. I don't know. But the signs that you look for, at least I think for people, they're very subtle. And I like to start with how they grip the objects or grip their hands or their feet contact. And so when we go into this workshop, I think it's going to be very easy for people to ignore subtleties. And I think what we're going to have to do is break up very quickly into groups. And I I feel like this is going to be something that they kind of have to feel to get, and they have to be able to identify on partners to get. And so another thing I was kind of thinking about through this workshop experience creation for me was, how am I going to get people to interact? And I've been to a lot of seminars before, and people just sit there, sip coffee, talk amongst themselves a little bit, and have the same exact partners. And there's always the people too who don't want to do a bunch of interaction, but when it's a workshop, you kind of got to interact, and I've developed some really great friends from learning at workshops and grouping up with people, and I think it's fun. I like going to the Perform Better one just because the workshop itself is like, you get to work with a bunch of people, and so I don't always learn extra things at the Perform Better one. I do get some gems out of there, but this is why I kind of only go about once every 3-4 years. But I think it's nice to experience working with people. And so what I want people to get from this as well is, I want them to, number one, get the information that they came for. Make sure they don't leave with any questions that weren't answered. And I want them to experience a bunch of bodies. And so I was kind of thinking, I was joking with my friend, we were having a beer the other day, we were cooking a tomahawk again. And so I was asking him, and I was like, so he's not in this profession at all. And I said, how the hell should I get people to do this? And how am I going to get people to get the effect that I want them to have? And how am I going to get them to ask questions? Because I'm much better off Q&A than I am about presentation. And so he was talking about school, and how people, kids do things for gold stars. And so I said, yeah, gold stars, I guess, I don't know what the thing with the gold star was. Like, if it's really holds, like, people hold the gold star near and dear to their heart, or if it's more about the recognition they did something good and they were given something, kind of like a trade of currency, So I was thinking, I don't want to give gold stars, but I do want to foster questions. And I guess there has to be something that people want more than life itself. And I was thinking, since we're going to be cooking these tomahawk steaks, then it might be 2 or 3 of them. I'll have to take a head count of who's actually going to come over to the barbecue after. And actually, by the way, I'm a little afraid that I've never cooked 3 tomahawk steaks on my grill before, and I'm thinking about the amount of energy that each steak will take to cook. I don't know if I'll do them right if there's 3. 2 I can do. I've done 2 before. 1 certainly. 3 might be a little bit of an issue. And people probably might be having some beers waiting that good hour and a half to go indirect on the things. But we'll see. So anyways, there's going to be 2 or 3 tomahawks. I don't know yet. So kind of the rule of thumbs with tomahawks for me is, if there's someone who has never experienced eating the meat off the bone of the tomahawk, they need to. And so I really look to give the tomahawk bone to people to eat, to have them have that damn wow experience, And so there's only 2 or 3 of them. That's the problem. And so each steak is so damn big that feeds 4 to 5 people. And so if we have 10 people wanting to go to the barbecue and have beers after, then we're only going to have 2 bones. And so I was thinking, so that Saturday, since it's a 2-day workshop, that Saturday I'm going to have these made. They're going to be gold tomahawk stickers. And just these little stickers, like kind of gold stars, but tomahawk stickers. And so I thought I would give these to people. And so whoever ends up with the most stickers at the end gets the bone. And so I want to make sure, though, that they're quality questions and that they take some thought, not just, hey, what kind of underwear are you wearing today? And they're going to get a gold tomahawk. And so I feel like this will help me out a lot with this workshop, because if I run into a hole where people don't know what I'm talking about, or if my communication's poor, then I need them to make me clarify. And I think probably over the last few seminars that I've been to, I've asked a lot more questions, and I've learned something, learned a lot. I remember going to the Perform Better one I went to last. There was Dan John was on stage talking about bear hugs or hugging something, right, to create internal pressure. And so he was talking about we're talking about a drum, I think, or like a trash can or something to that effect. And so I said, how do you want it smooth, or does the texture matter? And he said, actually, if it's smooth or greasy, it's better, because it cues them into holding it harder rather than just fingertipping it. So I want them to create like an anaconda type of pulling it in, crushing it from all sides, even from the belly. And so I learned something from that because I asked the question that no one else asked. The last time, actually, I went to the Fix Your Own Back seminar. I asked Philip what we talked about. We're talking about progressive motor loss. And so he said if there's not any improvement in motor loss or they're progressively going downhill, then we got to offload these people. And so I asked, because I wasn't quite sure, and I've never shadowed him in practice, I said, so when you say progressive motor loss, are you talking about motor loss from before you got them, or motor loss continually after you have initially started your care with them? And he said the latter. And so that's gave me. I feel like it gave me a good comfort there, like knowing that it's okay to work with people with some motor loss, because if you just offload them, like as soon as they have like the first hint of motor loss, then if you offload them to a surgeon, they're going to get surgery, which might not be a thing. It's just we just have to deal with it very quickly. And so from that point in time, since I've worked with people with some motor loss or some hand issues or even foot ones, is that, and we'll test them in a quantifiable way, doing something for reps and also subjective outcome measures, subjective and objective outcome measures, is that I'll make sure that the correction that I suggested that we tried improve their number of reps, as well as improve their subjective feeling of was it easier or not. And so this has been helpful to me to not be quite as scared of these types of cases, but also being very definitive with what I expect of them. And so I know those are tangent topics, and this is a big tangent, I guess, podcast today, is that, and so with those people, which I don't love getting people with radiculopathies into the hands quite that much. Lower extremity ones, I like them better. But the hand ones, the inability to, like use small objects, it kind of freaks me out, and so I don't get them in that situation very often. When I do, I'm extremely cautious, and I make sure that I have co-managed them, and I don't do anything fancy. I just look to see if something simple will help them out with that. Because those red flags, man, like it's definitely a thing we got to co-manage or at least refer out for. They got to make sure to get them on their way if they need a surgical correction. But anyways, so people who have radiculopathies or long-standing ones, I tell them straight away, because I don't want to be the guy who burns all their time. And by the way, I guess I should retract on those motor loss patients. Oftentimes, those ones on the first day, I tell them they need to have an image done if they have not had one done already, and they need to go see a neurologist. And so I make sure those are on their way. And if there's a waiting time, a lag time in there, then I'll do some further investigation. I kind of think of it as a quarterback approach on those people. And so I might not be willing to really administer care, but they also need some guidance. And so I try to be more of a quarterback on them. So people with more of like a long-standing radiculopathy, and they're kind of not getting better, and they've tried a bunch of things, I tell them, look, man, like I want to be straight up with you. Like I want to make sure that we make a definitive change really soon. Like, I mean, within under 2 weeks. Like, I want to see that the things that I've tried with you have made some type of improvement for the better. It might not get all the symptoms away, but I need to see that what I'm suggesting for you makes a change. And sometimes it takes time for the full change to come back, but I want to make sure that it is happening. And I tell them, look, I'm going to be very serious about this with you, is that if I don't see that change, then I'm not going to see you anymore. And I'm going to suggest that you go to somebody else, and I can guide you at that point. But I want to make sure that we're on the same page, is that I expect you to come in a couple days a week for a few weeks. I need that from you. If you don't do it, then I'm not going to know if the things that I'm doing are helpful to you or helpful for you, and you're just going to float around in no man's land, and I can't have that. You can't have that. You're not going to get better from that. And so if you're going to be with me, then give me a solid time frame to work with you. to make sure that I know that I'm on the right page, because I might be the wrong thing for you too. And how did I get on this? Anyways, radiculopathies. Asking questions, right? And so I do want people to ask questions. And so you guys too, on the other side of the podcast, if you have questions, I love questions, right? I did have someone recently reach out to me who was talking about they wanted to hear more about a certain type of sport and ways to reduce symptoms surrounding that sport. And so I want to be clear that I don't do online consults at all for patients. And so they asked about online consults, and I said, well, no, we don't do that, but we do have I do have availability for clinicians. And so if you've reached out to me before on Instagram or on email, I respond as quick as I can, sometimes within minutes. And I want to help other clinicians, or I wouldn't be in this continuing education game and trying to improve the profession if I can, and I wouldn't be doing all these podcasts. So I do want to help people, but at the same time, if you want to be helped, I want to make it available so everybody can see the help that was implemented. And so if you do ask for a question to be answered, I'd like you to give the ability to have that question answered on air or via a video chat, and I'll probably record it. And I've done this with a couple people with their websites. We did tinkering with it. There was no charge for it. All I asked was that they referenced that I helped them with their site in a certain way. If you've done that with me, then you know what I'm talking about. But for the most part, we recorded those things, and so they're going to be available for other clinicians to look at, because I think we all should be learning from each other. Just like in this workshop, I expect people to fail at things, and I expect us to improve it together, right? Although I'm presenting stuff on things, I don't expect to do all the work. Although I know with the CE platform, they want you to have stuff to present. I do have stuff to present, but at the same time, we learn from each other. And I think we know that with working through chiropractic or PT school, is that we learn from others' questions, and we learn from others' mistakes and others' successes, honestly. And it takes practice. And I think Ben Ramos talked about it with me. I don't remember from person or on the podcast, but a lot of times your workshops with manual therapies and all this kind of stuff, it's just that we're forced to be in a room, I think, together, and then we're forced to practice so we get better at it. And so I'd really encourage you guys to get together with each other. Someone who works by you, maybe someone who's an hour away, go have dinner with them after doing some practicing. And me and Ben do that. I've shadowed Cody before as well. And so I think we all learn from each other in that regard. But back on the whole point here is that if you want direct attention and want it anonymous, please reach out to me still. I'm going to start putting together I don't like the sales aspect of shit, honestly, and I'm not trying to, this is not anything I ever wanted to do or even consider doing, but the more people reach out, I do want to help, but at the same time, it's going to come at a little cost. And so if you guys want one-on-one attention and you just want to do a phone call that's not on air, not recorded, and so on, like, I have no problem with that. It'll cost a little bit. It won't cost a lot. It'll just cost a little bit for my time. And again, I think over the last few months, there's been more call to actions for everyone, all the listeners, to either help out someone. I mentioned in one podcast we were doing I have a folder in my Google Drive that it's called Helping Others and giving back. And I've asked for people to review other people's Instagrams. I've asked people to review other people's podcasts. I've reviewed people's podcasts. I've asked that you guys check out our Pro Chiropractic Online as well as this workshop. And so at the same time, I have received emails from a couple of docs that said, I really love your content. You don't leave anything out, and it's all in there. And one guy said, I really love how you have a really soft way of selling. And I said, thanks. I really don't want to sell anything, but at the same time, selling gets people in It gets people in the game. It gets people to have skin in the game. And so I said, look, I love doing the soft selling, and I'm sure that you guys have noticed that I've suggested some things over the months, and I don't like to be pushy about things, but I swear, if one of you has a problem with being able to treat and having any question about how to treat a low back condition, acute or subacute type of low back discogenic related condition, if you're not taking that online course, you're missing the boat. Okay? It does cost money. I want you guys to go through, because if you, like, we've given it away to a couple people to look at, and I know that there was part of the people who were helpful in filming it with me, they had access to it, and I gave them a coupon code on the site, and I can see if they've used it or not, and literally not one single person from one grouping used it. They said they wanted it. They said they wanted to watch it. No one used it. And a couple of them are students. They could have used it. And so I want to be clear on this, and if you guys are starting to build your own practice, is that if you don't charge something for your services, no one's going to do it. Like, no one values it. And I know you probably heard that before, that no one values your work. It's not about like being a valuable artist. It's being paid for your art, and only people value your stuff as much as you value it. It's not about that. It's about, like, literally you will not help anybody. Like, no one will do the work they need to do to get better. And so the call to actions, and this is the big no-no with call to actions, is don't have too many at one point, because people get confused. But I want you guys to act. And I want you, number one, if you have a question about how to start business, or if you have a clinical question that you are asked, that you're wondering what I would think about it, or if I have a podcast on it, or if I have any guidance on it, I'll tell you if I don't know. Like, I'll just shoot me an email. If I don't know, I will tell you I don't know. If I have some gems to share with you, I'll share with you. It'll cost you a little bit, okay, unless you want to do it on air. Because I'm always looking for content to share with people, unless you guys want it solely on your own. And if we do it on air, it might take months for you to get it, honestly. Or sorry, it won't take you months to get it. It'll probably take you weeks to get it, because we'll record it well ahead of time. And I'm a few months ahead on air, and people won't hear it for a couple months. Second thing, again, is if you have a problem with treating flexion intolerant backs like discogenic symptoms, which honestly are going to be a lot of your patients, because chiropractors should be good at this, you need to go to that thing. Okay, it's Pro Chiropractic Online CE, Pro Chiro Online CE. All right, it will literally change your whole damn practice if you don't know how to work with a disc. All right. Third thing is that I've already released the first hour of this workshop that I'm putting together, because I want you to understand the theories and premises that I'm working off of. And I had a couple people ask, like, "Hey, I can't make Saturday. Can I just come Sunday? I really want to come Sunday." And I said, "Look, if you don't know what we're doing, it's kind of like I've had interns who have stepped in to my practice, and I'm working with someone, and we just start going. And at the very end, they say, what were you looking for in this person?" And so the moment's no longer there anymore. And so I want to make sure that everyone does have some type of understanding of what we're doing with loading. And I remember when we did podcasts, I think like 121, 122 with Cody DMAC, we were talking about loading patients, and we had a question from one of the listeners that said, "What do you mean by loading?" And we are going to recircle on this thing, but if you want direct questions and you have direct things that you want answered, ask me. All right, I'm here to help you guys. The workshop in itself, I don't know if you've heard all the other podcasts I've done about this workshop, or how I've kind of gotten into the continuing education thing. Is like I didn't even intend to do this at all. Like we wanted to get together with our some classmates, have a beer, and get some CEs in the meantime. And so, as I'm putting this together, I realized, holy shit, I shouldn't have done this, right? But also, I see the value in it too. And so, if you guys don't know how to use a corrective exercise to get someone's symptoms reduced nearly immediately, within a couple minutes, ask me. All right, I'm open to sharing. But at the same time, if it takes a long time, then I'm going to ask for a little bit of money and in exchange. And so this isn't a hard selling. I'm just being real with you guys, all right? There's a lot of things that I was afraid of asking in workshops before that I should have asked. And so with those golden tomahawks, if you're attending the workshop, I hope you get all the gold tomahawks. I want you to get the tomahawk bone in your hand and just dominate it. I want that for you. So I think that's all I really have to say today. This is going to be a short podcast today. But I guess thank you guys for listening, because I think after talking this through with myself, by the way, if you guys don't bounce ideas off a mirror sometimes, then you keep them all in your head and it's hard to sleep sometimes. So I want to thank you for listening. And if you have suggestions for me, like, I'm all ears for this thing. And maybe this doesn't help me the first time through the workshop, because this might air after the workshop. But I'm certainly open to doing it again, because this thing's taken quite a few months to put together, and I can only do it in the morning because I get distracted by things in the afternoon. So like cooking steaks and messing with people's problems and so on. And so anyways, contact me. The show notes are on p2sportscare.com. You can access all of the old ones podcasts on the website as well. iTunes stopped letting us do episode numbers, or else I can recite most of the episode numbers that I really loved. Michael Shacklock did a really great one in 91. Thomas Show did in 94. It was amazing. Doc Stu McGill was on 67. But again, pretty soon, when we go back and remove the numbers, you won't be able to do numbers anymore with it. So just go onto the website and type up those names that you're interested in, or the topic you're interested in. And what we're working on with the website is, over the course of the next few months, we might be giving it a facelift and improving its searchability. I want to make sure that everyone's able to go through there and find what they need, because I have a lot of content to share, and I know, just like with Instagram and YouTube and all that kind of jazz, it's hard to search for old stuff, and I want you guys to get the old stuff, because it's pretty banging, honestly. I've learned a lot through interviewing people and expressing my ideas over air. So as always, leave people better than how you found them. And if you're dating Eagle Scout. And I'll talk to you guys next week.